Please bring the live pictures on. Dr. Roman, good morning. I'm Dr.
Good
Roman
morning.
from India. It's good to see your live surgery today at SERGS.
We are seeing now the case. You want to introduce the case, or we read the case in the slide?
No, you can. Yeah, I can introduce it because I saw the slide. I see the slides on my computer.
Yeah.
So it's a 43-year woman with 8-year infertility, with moderate dysmenorrhea and deep dyspareunia, but her problem, or the catamenial pneumothorax, recurrent every 2 to 3 months during the last 5 years. So she had one surgery by VATS, where the diagnosis of endometriosis was made on a biopsy. They tried to suppress the pleural cavity by a pleurodesis, but the pneumothorax continued to occur. The last one in January, where she has a chest drain. The problem of this pneumothorax, they are due in a majority of cases to holes into the diaphragm. We tried to see them on the MRI, but the MRI was negative. But this does not mean anything, because the MRI is negative in 50% of cases who have the surgery for endometriosis. So we planned robotic surgery in life for your congress, and we'll excise the area involved, the diaphragmatic area involved by the holes, and we'll suture. And in most of cases, the pneumothorax do not longer occur. So the patient is placed in lateral decubitus. You see the placement of trocars, and now we can go to the live surgery to show you what I found.
We can show that you are going to just use the 3 arms, not the 4 arms.
Yes.
Okay.
Yeah, with the diaphragm, on the diaphragm, the 3 arms is quite enough. Okay. And you will see, I will place 1 or 2 trocars for the assistant. Today I placed 2, 1 for a retractor and 1 for the suction and the assistant grasper. So you see, when we created the pneumothorax, the pneumoperitoneum, we saw only this part of the diaphragm above my instruments, so nothing was apparent. But once we pushed the endoscope and we saw below we look at behind the liver, we found these lesions, and the pneumothorax occurred spontaneously because the CO2 we inflated into the abdomen went inside the pleura. So this is not a very difficult case, because we have holes, we have the origin of the problems. We need to resect this area, which is not very large, and then we'll suture. What we have to pay attention to this is the suprahepatic vein. So the surgery should be done very carefully, because an injury of this vein is the nightmare of surgeons and patients. So I will start by releasing completely the liver, incising all this peritoneum and in front of the suprahepatic vein. The liver will go down, then I will resect this and I will suture. The robotic surgery, the robotic assistance in this surgery is determinant, is crucial, and I cannot hear that the robot is not useful, because it makes a huge difference in the treatment of diaphragmatic endometriosis when compared to the conventional laparoscopy. Yeah. So I know we are free operative rooms in parallel, so I start working, and you can continue with one of my colleagues.
What are the instruments of choice and the energy settings that you have based for this diaphragmatic excision?
Yeah, I always use scissors on the right hand and the bipolar Maryland on the left hand. My assistant has a grasper and a suction, and when the lesions are very or behind the liver, we can place a supplementary trocar in order to place this liver retractor. So we start by incising the peritoneum, and we'll mobilize completely the liver. You will see the liver will go down, and this will allow us to have a very large edge of diaphragm to close. So we published last year, I think, a series of 60 cases of robotic robotic surgery in diaphragmatic endometriosis. We completely stopped doing this surgery in laparoscopy, I think, 7 years ago, because once I did the first time with the robot, I understood that this is the way to treat them in the best manner. And I hope this that today I will convince you. Now we say it is not difficult to convince you because it is a robotic surgery congress. But anyway, I continue to state this each time I have the opportunity. There are some indications for the in the endometriosis where there is not longer debate between between the robotic and the laparoscopic surgery, and the diaphragm is one of these localizations. The other localizations are, in my opinion, the sciatic nerve endometriosis, sacral plexus endometriosis, low rectal endometriosis, urinary endometriosis, the disc excision in rectal endometriosis. So progressively, the robotic surgery, in my experience, replaced the laparoscopy at the point that if I want to schedule now a robotic surgery, the first available slot is in October, end of October, while a laparoscopy I can schedule even in June, because the most of my cases now go to robotic surgery. And you have to know that there was a time where I considered that I can do everything I wish in laparoscopy. So I am a laparoscopic surgeon who almost completely moved for the complex surgeries to the robotic because of the quality of the work. And this
we
is
are
longer.
Switch to another with Tommaso. Tommaso is starting the surgery. Tommaso, can you hear us?
Yes, I hear you.
Yeah, Fluvio. Yes, I can hear you well. I thought I would start with something that is less interesting, so to allow for us to start this procedure. So the procedure that I have to do involves an anterior and posterior dissection and a supracervical hysterectomy. Now, I generally start with the dissection, but I wanted to start with the supracervical hysterectomy because Horace was starting his procedure, which I think is extremely interesting. So I didn't want to take out time. So let me know if you want me to start with the dissection.
So here is the suprahepatic vein.
Preparatory stuff, and then we go back to our OR later.
Yeah, you can start because you are in the main screen. So
perfect,
continue.
Perfect. So then I will ask Elena. I will stop. I was preparing the left ovarian pedicle just to start with the supracervical hysterectomy. But I will start with the steps which are more interesting, I think, in view of the correction of the prolapse. So Elena, who's actually manipulating, I'm asking Elena to push the uterus inside and down and central. Perfect.
What kind of uterine mobilizator are you using? roomy?
Okay, so we are using a number of very interesting tools today. The first tool that is interesting to be recalled is the hub. This is a connection to the robotic platform.
Attention, ne pas toucher la veine.
Today. So you are hearing me because of the hub platform. We're actually using a very interesting
okay.
today.
I have everything.
Endoflator Plus, produced by Karl Storz. It's a new
now we'll excise this
and aspiration tool, which warms up the CO2. It's very interesting. We tried it very recently. It's a newly introduced instrument. It works very nicely. What I think it's very, very important for this type of procedures, Elena spingi per favore dritta, is the use of a very precise manipulator. So there's different types of uterine manipulators you want to use to do pelvic floor reconstructive surgery. We like a lot the Shar manipulators. It was devised by Professor Shar. It's a very simple manipulator. It has a long pole that can be introduced and retracted inside the uterus, and a broad part that distends the vagina. So it helps a lot in identifying the dissection plans and also to fashion the mesh over the vagina. So it's very simple. So it's just one instrument, and it makes things easier. So the first step in the procedure is to identify the bladder vaginal, the vesico-vaginal septum, and to start dissecting, so to find the anterior vaginal wall. As you can see, we're using two arms, operative arms plus the scope, and one assistant axis, which is a grasper. We're using a standard bipolar. It's a fenestrated bipolar because during this procedure you have to grasp and suspend a lot. So it's I find it more effective than the Maryland instrument in this case, and the usual standard monopolar scissor, which is extremely effective in doing dissection and in coagulating. So we are entering the vesico-vaginal space. So our job is to grasp the bladder, take it up, and to ask Elena at the manipulator to push strongly and get the uterus a little bit further down, okay, so that it helps us identifying the right dissection plan. And we need to identify all the space as deep as we can. So we need to go down, 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 so that the mesh that we will use will cover efficiently the bladder and the vesico-vaginal space completely, because this patient, as we have said, has a very advanced anterior prolapse. So this is important. So the way we decide to dissect changes based on the type of prolapse we encounter. So it's prolapse surgery is a very tailored surgery, of course. So we need to be aware of what the patient has and to personalize. So you're starting to see the bladder here. The bladder, there's a Foley catheter inside, of course. And while we go down, it's easier to identify the right dissection plan. We need to stay exactly between the bladder and the vagina, and for several centimeters of dissection, it's quite easy to identify this dissection plan.
Tommaso, how are you deciding the end point of dissection? What is the landmark for your
sorry?
Tommaso, what is the last point of your dissection, end point, landmark?
Okay. Thank you for the question, which is absolutely relevant. So we are now dissecting over the cervix.
Bougez pas.
Upper third of the vagina. So we are still quite far. I suspect that the bladder is not completely empty.
We have here endometriosis too.
Foley catheter to see that it's not occluded, please, at some level. so that also in the room they see it better. But the dissection limit is actually given by the anatomy of the lower third of the vagina. So when we get to the lower third of the vagina, the space doesn't open as easily anymore. You have a restriction of the surgical field, which is motivated by the fact of the differential embryological origin of the lower urinary tract of the lower third of the vagina as compared to the upper third of the vagina. So Elena, please push again. So it's something that you realize while doing the surgery because it becomes more and more difficult to open the space. You have more vessels you encounter.
While you are making the dissection, we are going to pass to Roras because they open all the diaphragm and we can see the lung. So Roras.
Perfect.
Yes. Yeah, so I opened the diaphragm. I resected all the areas with
it's a big hole.
Yeah, it is.
Yeah, but it's not so big because we have already done
very big.
What is interesting that once I resected this, I had a look inside and I saw here also over endometriosis lesions. So I will extend the excision to this.
Yeah. So the excision is mainly visual based because the MRI was negative, right?
Yeah, the MRI usually is negative, usually in 50% of cases, because the condition of the MRI are not easy. There is a muscle which moves all the time, and the lesions are rather small. So when the MRI is positive, you may expect to have huge lesions.
Okay.
So an MRI which is negative does not rule out the diaphragmatic endometriosis in women which are symptomatic. But an MRI which is positive requires caution because the lesions will be very large. So here we had a negative MRI, but as you can see, we finished by creating a hole which is not less than 5 to 6 centimeters. The largest we have already done is 12 centimeters, and we could close it correctly with the robotic assistance. Now, what I want to emphasize that if you look at the seria of patients with diaphragmatic endometriosis treated by laparoscopy, and one of the largest series is that of Marcello Ceccaroni, which is a very good friend and is the head of the largest department of endometriosis in the world. So they are actually masters in surgery of endometriosis. But if you look at the rate of women with transfixion lesions, there is not over 15%. 15%. While if you look in our article with robotic management of endometriosis, the rate of excision of the diaphragm is 75%. So it looks like in laparoscopy, we try to find the argument not to open the diaphragm because it is not easy to close. While in robotic, this opening the diaphragm is not problematic at all because we can close it very, very easily. Now, what we want to do is also to go into the thorax and to see if we have some lesions. Usually we have not, but we can explore carefully all the thorax. You see, in 2022 she had a surgery where the chest surgeons tried to induce adhesions between the lung and the pleura in order to avoid the new hemothorax. I think that the pleurodesis in endometriosis should be avoided because it will render very, very, very difficult the excision of diaphragmatic lesions after the pleurodesis. So I think there is a message I want to send to everybody, please avoid any pleurodesis in patients with diaphragmatic endometriosis, because the surgery is very difficult later. And not earlier than 2 days ago, I refused to receive a patient from France who had 3 chest surgeries with pleurodesis, talc, and now she has the hernia with liver, and they sent me to treat her by robotic, and I said, I'm sorry, this is actually too much. I think everything was done that the lung be adherent to the diaphragm, while when the lung is adherent, when you open this and you have the lung behind, you can injure it, and this is not very pleasant for a gynecologist, because let's recall that I am gynecologist, as most of you. So we are not supposed to create injuries of the lung when we perform our gynecological surgery. Okay, now
you use the camera at 30 degrees.
Sorry?
You prefer the camera of 30 degrees and then the 0 degrees?
Yes. For the lung, 30 degrees is mandatory, because you need to see here, yes, behind the liver. So the 30 degrees is mandatory, in my opinion. Okay. So here we have the suprahepatic vein, you see. So this is very easy to injure it if you come with harmonic scalpel or with instruments without being aware that it is there. And now I will start suturing. So I will suture with V-lock, resorbable V-lock, and I will reinforce with Mersuture sutures. And I think I will change to the soon to the non-resorbable V-lock, because I heard that it exists. Okay. So we need to do to place a suture, non-resorbable suture. Okay. So the suture in robotic surgery is easy to do. It will take maybe 20 minutes. So you can visit another operative theater the time I do this slowly but steady in with robotic assistance.
Well, we are going to switch to Tommaso again while you are changing
Aspirez ici déjà.
For the driver. Tommaso, you are making the hysterectomy.
Yeah, it's a ovarian ligament.
Tommaso, you are in the central screen.
Et mettez-moi deux porte-aiguilles.
Hello, Tommaso, please, in the central screen.
Dissected the bladder. You see how deep we are? We are down under the bladder trigone. You can see what I was telling before. There's a triangular shape.
You go to cut the adhesions in the thorax.
This is the place where you want to stop. Now, you get the uterus up, Elena. I think you've seen in the lateral monitor my opening of the Douglas pouch and a dissection, which is not as deep as we used to go. I have a 30-degree scope, towards the upper part. This is the rectal wall. This is the upper vaginal wall. This patient has a second-degree enterocyte.
Le trocar va sortir bientôt, c'est lui qui est des ciseaux. Non, des ciseaux.
The closure of the Douglas pouch.
Donc mettez le porte-aiguille et poussez-le juste un
place afterwards. So I was starting, and Elena pushed the uterus on the right side in performing the supracervical hysterectomy. This patient is postmenopausal, so we'll move the next as
well. Mais mettez-le alors comme ça.
Ovarian pedicle.
Tommaso,
the vessels here.
Tommaso, give me a second, because we have the hysteroscopy case. So we are going to present the case, and later we are going with you again. Okay, we are seeing you while you are making the hysterectomy.
Sure.
Okay, the hysteroscopy, please. Could you present the case?
Good morning.
Good morning. Good morning. You are in the main screen.
Yeah, and
I'm going to thank Dr. Vitosera for the organization. It's a great pleasure for me to scan performance on patients who will soon undergo surgery with Professor Attilio Spezio. This is a 54 years old female woman.
Right.
Okay. That due to EV and irregular menstrual bleeding has to perform an ultrasound chart. You can see longitudinal and transversal plane. And so even if you can see the midline endometrial,
Ti almeno spinto però, non ti sbosciare. Ho bisogno che tu stia sempre in spinta, ok? Spinta senza muoverti a destra e a sinistra. Spingi verso la destra e stai. Andiamo a fare...
Here in the Hysteroscopy room, we can see this homogeneous thickness of endometrium, and with coloscore, we can see also the feeding vessel, so we can suspicion of a polyp. It could be around 16 millimeters.
Okay.
And so I give the words to Professor Di Spezio.
This is Attilio Di Spezio. So I thank Tommaso and Vito for the kind invitation. Of course, I know that I feel a little bit embarrassed to speak after endometriosis of the diaphragm, purpose acropersy, we have to speak about the polyp. But I mean, we can impress you the quality that we can in surgery.
Attilio, we don't have a good audio from you.
Ah, you don't have audio. So, could you hear me now?
Yeah, but no, with no good signal.
Okay. You have audio good now?
Yeah.
Okay.
Yeah. Okay.
Is empty?
Okay.
Okay. I think it's better. So I was thanking Vito and Tommaso for the kind invitation. I think I'm very embarrassed to interrupt such wonderful surgery about diaphragm, endometriosis of the diaphragm and colposacropesy to impress you with the treatment of an endometrial polyp. But this is life, because many times happens that even during robotic surgery, we think that the problem is outside the uterine cavity, but then we have the problem inside. And you see the diagnosis, the sonographic diagnosis of Francesca was perfect, because here we have a polyp, is a long, occupies the cavity. And the only way I can impress all of you, it's through the speed of this device that we are going to use. Tissue removal device since 2005 represents one of the gold standard tool for the treatment of intrauterine lesion, mostly for endometrial pathology. And you see, while I'm speaking now, you see that the device is doing its job. This is something, Giuseppe, before, but we in our department, this kind of treatment of endometrial pathology in outpatient setting. So rather than thinking if we have to do or not the hysteroscopy, we already have done, and we already have done the treatment of endometrial polyps, endometrial pathology, and mostly for this lady, perimenopausal age with thick endometrium. We have to admit that in many centers, people still rely on blind technique like DNC. And then because there is the recurrence of the pathology with blind technique, at the end it finishes with an hysterectomy. Today we have the possibility to go inside the cavity, to clean the cavity itself, and to resolve the problems of the patients, because she has polyps. We can ask for histology. We can do what we call the visual DNC. we take the advantage of the blind DNC, so we can take a lot of specimen, and we are using a 4 millimeter, the end is 5 millimeter, the complete diameter of the instruments, but we go inside the cavity without dilating. We see we have cleaned all the cavity. We check that there is nothing more inside uterine cavity. And even if there is blood clots or cervical lesion, as we see here in the cervical canal, you can clean everything. I know I love robotic surgery. I have to thank Vito, Giuseppe, and Gabi that have been my proctor in robotic surgery. I think I'm not so good to be invited to be do the robotic surgery, but I think that many surgery requires the combination, and we show yesterday in the course about the treatment by hysteroscopy and the treatment by robotic, because sometimes we think that the problem is outside the uterine cavity, but at the end is inside the uterine cavity. And the combination of these two techniques allows to resolve the problems. And this reusable shaver allows to resolve the problems with minimal cost, because the blade is reusable. It's a 5 millimeter instrument, which means that we don't dilate the cervix. Even if there is mucus, blood inside the cavity, you can clean the surgical field before doing the proper treatment. If there are an abortion cyst or cervical polyp, you can treat all the pathology, and you can also use 3 millimeter and 5 French instruments. So I thank all of you for the attention, and we show that, I mean, sometimes even a quick and safe hysteroscopy can let robotic surgery to go ahead with the effective treatment of the problems of the lady. Okay. Thank you, and we will see later for another pathology and treatment. Okay. Thank you.
Thank you very much. We are going with Horace. Horace, you are finishing the suturing the diaphragm.
Yes, I am progressing with the diaphragm. So I progress with the V-lock, and then I place some non-resorbable sutures every 5 to 8 millimeter distance, because the unique complication we had after this surgery is the long-term or mid-term diaphragmatic hernia.
Yes.
So we observed this diaphragmatic hernia in 5% of patients with diaphragmatic endometriosis excision, which is not very much, and maybe it's comparable with the rate of diaphragmatic hernia, which are spontaneous due to the endometriosis itself. But to avoid them, we try to place. I got this. We try to place the non-resorbable sutures. We do not go to placing systematically a mesh, because I think it's not necessary. Second, the mesh will induce strong adhesions with the liver, and if we have a recurrence, we have not had yet, but we may have in endometriosis, it will be very difficult to come back and to treat. So we try to avoid the mesh, systematic mesh placement. What I want to say that the pneumothorax is our friend during this suture, because the lung is far and we do not risk to injury it. That's why we'll keep the pneumothorax until the knot, and when we'll do the knot, we'll aspirate the pneumothorax before closing the knot, and like this we never leave a chest drain, never, in our patients. And our patients leave the hospital the day after. So tomorrow morning they will have, leave it please. Tomorrow morning the patient will have an X-ray just to make sure that everything is okay, and then she can leave in very good shape. Yesterday evening I carried out another case like this, and the patient is ready to leave. So the outcomes are almost spectacular, because the patients feel very well. The pain disappears in 90% of cases. So very, very rarely the patients may keep a pain in the right shoulder. So the results are actually very, very good. Now I will take another MER suture to finish here. And before doing the knot, I will show you how we aspirate the pneumothorax, and then the surgery is finished. That's why our diaphragmatic endometriosis cases are usually scheduled at the end of the day around 5 o'clock in the afternoon, because we are sure that we finish at 6:30 or 7 when we are supposed to finish our operative program. So very, very rarely we have surprises which increase the operative time over 1 hour and a half. So this, I think, is the first time we schedule a diaphragmatic surgery early, because usually they are scheduled at the end of the program because of the standardization of the technique. We published 3 years ago, I think. Yeah, 3 years ago. A video article with diaphragmatic endometriosis robotic management in 10 steps.
Okay.
So I think it is in GMIG, and if I remember well, we paid the full access, so we can have a look at this movie, which was awarded. We received the prize for the best movie of the year 2020. Yeah.
You are finishing, so the surgery is done. So thank you very much. We are going to change the screen with Tommaso. Tommaso is just removed the uterus. So
okay,
continue with him. So thank you very much for your.
And we'll see this evening, because my flight is 4 o'clock.
Okay.
So I will join you for 2 days of Congress, and I am very happy. How is the weather?
The weather is lovely here.
Yeah, lovely.
Yeah. We are looking forward to seeing you at the meeting.
Great. Very well.
Okay.
Very, very, very well.
I just ask one last question. Horace, I just want to ask one last question. At the end of this suturing, is there some reason or some way where you will actually get into the pleural cavity and release that gas, the pneumothorax that was created?
Yes. Now we'll just 1 second to show you how we're doing. Come, Milen, with the aspirator.
Yeah, that's what. This is what we wanted to see.
Yes, this is the last step, which is important to see. So Milen, my assistant, will go inside with the aspirator.
Before you close the wound completely.
Okay. Milen, is when you wish. Jeff, expand. Okay. Let's go. Aspiration. Aspiration, 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 expand. Okay, was finished.
Thank you. Thank you for sharing this.
So thank you very much.
We do not longer have pneumothorax.
Okay. So we are going to put Tommaso, the surgery of Tommaso, in the screen. So thank you very much, Horace.
Thank you. Grazie mille.
Yeah. Thank you.
See you this evening.
Tommaso, you remove the uterus and you place sticks of Prolene, I think.
I was listening to Horace. It must have been a very exciting surgery. So I'm absolutely quick.
We are excited by your surgery also. Could you just take us through the few steps that you did while we were not with you, Thomas? I saw that you have dissected the anterior.
Let me recap. No, but I know you're seeing on the 3 screens. True. We removed the uterus. This is the cervix, as you have seen. I hope you have seen that manipulator we are using with a small tip that can be retracted.
Okay, venez couper, s'il vous plaît.
cutting the uterus on the isthmus very easy because you can retract the tip while highlighting where the cervix is. So I'm now waiting for the mesh to be introduced, and as a side thing, we've suspended the bladder peritoneum up, so not to have it in the middle of our surgical field when we will start.
Merci beaucoup.
The mesh. So let me, a couple of words on the mesh.